Good evening, and welcome to our Columbia Children's Health webinar. Tonight, we'll be talking about back to school with a spotlight on sports for kids. I'm Jennifer Ratner. I am a pediatrician, and I am also the Director of External Affairs here at Columbia. I want to give a warm welcome to our webinar audience tonight. We have an audience of pediatricians, coaches, athletic directors, and parents as well. And our expert Columbia Children's Health panel tonight will include Dr. Rachel Lewis, a general pediatrician, Dr. Charles Popkin, a pediatric orthopedist, Dr. Arthur Mandel, pediatric neurologist, and Dr. Rachel Weller, a pediatric cardiologist. A few housekeeping items before we get started with the discussion. If you need to leave early or if you'd like to rewatch this webinar, you will be able to find it starting tomorrow along with all of our other webinars on our YouTube channel, Columbia Children's Health. The chat will be disabled during the webinar, but the Q&A will be open for questions, and we will try to get to your questions towards the end of the webinar. And I'd just like to say that we have a disclaimer, which is that the content on the webinar should never be used as a substitute for direct medical advice from your physician or from another qualified clinician. So it's not specific to your athletes, children, or adolescents. But with that, we are going to have excellent content tonight from our really excellent Columbia Children's Health panel. And I will start with Dr. Rachel Lewis, who is our general pediatrician. And she will speak to beyond those school forms that many of you have been dealing with in various ways. And why do we screen before athletic participation? What is the difference, Rachel, between the regular annual physical and the pre-sports physical? And she will talk to us about the goals of the pre-participation physical exam. So with that, Dr. Lewis, I give it to you.
Thank you so much, Jennifer. I think that the goal of a sports physical is really to get anybody who wants to play sports onto a court, into a pool, onto a horse, whatever it might be. So it sounds simplistic, but we want that to be a safe and fun event. And we don't want it to be such a hassle for you to get clearance that you never get to the sporting event. So I appreciate everybody joining us tonight. A quick background about me. I'm one of the general pediatricians here at Columbia. I've been in practice in New York for about 20 years. And I think by now I have seen every sports clearance form and school form in the tri-state area. I've seen them all. So my goal is to give you a sense of the way the sports clearance process works, both from the perspective of me as a pediatrician, as well as for you as parents, coaches, and specialists. I'm sure all of you at every level have seen these school forms come across your desks: parents, coaches, school nurses, pediatricians, front desk assistants. This time of year especially, these forms come thick and fast. I think of them as a supplement to the annual medical form that we give to people for clearance for school, but they are not a replacement for it, and they have features that are different. So even though it seems inconvenient, it is important, and we do take it seriously. And there are ways to make it as effective and useful as possible, as well as easy as possible, both from the parent and the pediatrician side. So I think of this as a collaboration, right? We have the student, the athletes, we have the parents, we have the pediatricians, we have the coach, we have the school nurse. All of those people together are trying to make sure that those who want to play get to play and do so safely. So whether everybody likes it or not, the pediatrician tends to be the gateway to that participation. So we want you to play. We want you to have athletes who are safe on the fields, and we want to fill out your forms accurately. But on the other hand, we can't only fill out sports forms all day long. So I try to balance completeness with efficiency, both for you as patients and for us on the office side. It helps me to figure out how to do that if I understand why it is that we screen athletes. We want everybody who wants to play as much as possible. no matter what their underlying medical status is. I think that there is a sport for everyone, but sometimes we actually need to fine tune a little bit to make sure that the benefits of playing, which of course are considerable, outweigh the risks of competing. So you have 3 excellent panelists coming who will talk about specific issues that might prevent play in cardiac, orthopedic, and neurological domains. So I'm not going to spend a lot of time talking about specific disease processes. My goal is to help you understand what we're doing and how to make it useful as possible when you come for a sports clearance. I don't want to clear you for a sport if it would put you at risk. So in general, of course, as you all know, assessing a risk for sports involves surveying your current and past medical history to understand if you have a risk or an underlying condition that might put you at high risk for injury. So at the regular well child exam, which you're all familiar with, there's a lot of stuff that we review that of course is relevant. We need to know what medications you take. We need to know what you're allergic to, and we need to know that every time we see you. We need to know if anything changed in your family history. The day you were born and the day that you turned 16, a lot of things have probably changed for your parents, whether you as the athlete have noticed it or not. I need to know what you're eating. Do you eat vegetables and fruits? Are you more of a steak and potatoes person? Are you a vegan? Are you a vegetarian? Are you taking supplements if there's elements missing from your diet? I like to know what your baseline activity level is. Are you somebody who tends to be sedentary? Because that will change my level of comfort with you suddenly becoming a competitive athlete. We always ask about screen time. We ask about sleep. And by the way, 8 hours at minimum is necessary. We screen for stress, depression, and anxiety, and we discuss risk-taking behaviors, alcohol, drug use, smoking, sexual activity. We talk about school success, and we talk about family issues. And of course, there's an exam head to toe that assesses all the basic stuff. We take your blood pressure, we check your oxygen, vision, hearing, we listen to your heart and lungs, we check the rest of your body. Big assessments that are relevant in both regular and sports physicals are, for example, your growth. Are you done growing? Are you still getting taller? How does your weight balance with your height? And of a special interest is the stage of puberty, because where you are in your development affects your risk of injuries depending on the sport you're going to play. And you will hear more about this from Dr. Popkin. And of course, we assess your nutritional status and health in part from what we see on your exam. If you're really pale, maybe you're anemic. If your spleen is enlarged or you have lymph nodes where we don't expect them, maybe there's an underlying immune issue that hasn't yet been uncovered. Is your heart rate faster or slower than it was last year? Maybe there's a cardiac or a thyroid issue. So we're screening in a very broad sense for any problems when we take that basic medical history. And of course, we ask about and try to optimize any chronic medical problems that we already know you have, asthma, etc. For most of us, once you've been through all of that, that visit is full. You know, the 20 to 30 minutes that were allotted for your time in the office have been taken up. You go home with a regular school form, but most people don't know ahead of time at their checkup that they're also going to need a sports clearance form, especially if your exam is off cycle to the beginning of the sports season. So there's a few other things that we try to take care of in a sports physical that it's worth knowing ahead of time so that as a parent and as a pediatrician, you can prepare so that when you add another layer of investigation to what gets covered in an annual visit, even if you can't do it face-to-face, you're ready. So I think many of you know there are New York State and New York City pre-sports questionnaires. Most schools have their own version. The American Academy of Pediatrics and the Academy of Family Physicians also have pre-participation questionnaire forms and clearance forms. If you're a parent and you know that your child is going to want to participate in sports in the coming school year, it's worth asking your school ahead of time to know what they're going to require as clearance. And if there is a family questionnaire portion, and I guarantee that there is, fill it out before you come to the visit and bring it with us. Bring it with you so that later in the year when you need us to fill out the form, we have that on file and we're ready to help. From the pediatrician side, consider handing out a sports participation questionnaire at every well visit to offer a family a chance to discuss with the teen or the child at that time whether they might want to participate and answer those questions ahead of time. And then we'll have it available should the form come across our desk 6 months later. So that's the paperwork. And so what are we really looking for in a sports physical that we didn't cover in the general exam? On some level, there's not that much else, but it is a little bit different because we're looking for specific risk factors depending on what you want to play. The biggest one, of course, is the risk of a life-threatening complication. So we're talking about things like underlying heart disease. I think that the athletic nightmare that most of us think about is the sudden death on the basketball court that we see every now and then that turns out to be due to an undiagnosed heart condition. So severe heart disease or sudden death in another family member, for example, is something that we're always going to want to know about. And Dr. Weller will discuss in greater detail in a moment things like fainting with exertion, chest pain when you exercise, decreased tolerance for exercise that you used to be able to do, shortness of breath when you exert yourself. We're going to want to know in more detail issues like that. We also give special focus to updating medications and management of chronic conditions that really need to be in good shape before you participate. So I'm talking about things like asthma. If you have asthma, are you taking your maintenance medications? Do you have your inhaler? Is it expired? Does it still have doses in it? Have you tried using it? Do you remember how to use it correctly? If you have hypertension, have you kept up to date with your cardiologist? Do you need any sort of clearance, an EKG, a stress test? If you have diabetes, have you discussed your plans to exercise with your endocrinologist to make sure that you have resources in place for more strenuous levels of exercise than you've done in the past? If you have anemia, are you taking the vitamins that have been recommended by your doctor or hematologist? All of those things deserve a little bit of extra attention if you're going to be participating in a significant sports season. Of course, we want to make sure if you're somebody who's been injured previously, even if it was not a sports-related injury, that those things have been rehabilitated and well managed and are resolved. Sprains, fractures, dislocations, etc. Sometimes you need physical therapy. Sometimes you need to meet Dr. Popkin. If you haven't cured something or rehabilitated something before you start playing, I can almost guarantee you you're going to hurt it again and then you're going to miss the whole season. So we want to take care of those issues before you start play. And of course, if you have a history of head trauma or concussion, I'll be honest, I'm not a fan of football under any circumstances, but if you have had a concussion and you come to me and ask me to fill out a sports clearance form to play more football, I'm probably not going to do it. Full disclosure. Other examples might be if you're somebody who has a seizure disorder and you've been having breakthrough seizures, you really want to get your medications organized before you start playing water polo, because if you have a seizure unexpectedly in the water, it'll be hard for somebody to see that in the midst of a game. And of course, one other issue that doesn't always come up is that if you are somebody who has anxiety or depression and it's serious enough that it might make it hard for you to handle the stress of being on the losing side of a game, it's worth giving some thought to that and working with your therapist to make sure that you're prepared for bad as well as good outcomes. So once we've talked about the above issues, both the general medical exam issues as well as any more in-depth investigation, then we can do a physical exam that goes into more depth where it's needed. Look at strength, look at flexibility, cardiac or respiratory status, neurological exams. And of course, if it turns out that you don't have what you need to play, we can help you to fix that before the sports season starts. And part of that involves our specialists who at Columbia are always available to help. So in summary, what we're looking for is a balance between what athletes want to do and whether it is safe for them to do so. And our goal as pediatricians is to get everybody who wants to play into the pool or onto the field and safely.
That was a great summary and overview, Dr. Lewis. Really, really appreciate it, and a great segue into our specialists who are now going to speak. And now we're going to switch to Dr. Popkin, who is our pediatric orthopedist. And I know that all of us, whether we are parents, pediatricians, or coaches, know that we seem to be seeing more and more sports injuries these days. And Dr. Popkin, we're going to ask you to address what are the common sports injuries and what is what we're all hearing about that may be leading to these, which is this issue of early sports specialization and overuse injuries. So with that, I turn it over to our Columbia pediatric orthopedist, Dr. Charles Popkin.
All right. Can everybody hear me? Good. All right. I want to talk about something that's really passionate for me, which is pediatric sports. I love sports. I like kids playing sports. And I'm going to talk about a couple pearls for you guys to walk away with today. So hopefully everybody has a happy and safe sports season. So the landscape of youth sports has really changed. The days of sandlot baseball are gone, and now on ESPN, ESPN2, ESPN3, you can usually watch the Little League World Series where kids less than 12 are playing in front of audiences of thousands to actually on viewership to the millions. So there is a lot of pressure for kids to excel and actually to excel pretty early. One of my favorite quotes, whoa, sorry. I'm spinning, is from a sports writer, Grantland Rice, about
You ain't first, you're last. You know what I'm talking about? That phrase is trademark, not to use the tradition of Ricky Bobby.
Sorry, it forwarded ahead. So we lost the playing sports for the kind of the good of the game and to learn, and now it's all about winning is everything. Like Vince Lombardi, it's not everything, it's the only thing. Or Ricky Bobby and Talladega Nights, like if you're not first, you're last. I always love that. I don't really know what that means, but you get the idea when you live here in the New York, New Jersey, Connecticut area. So the days of kids really playing sports at their leisure is gone. I mean, back in the good old days when I was growing up, we picked the teams, we made the rules. Sure, there was some organized sports, but adults usually were not in charge. And what has really changed is we've sort of lost free play. That is gone. And some people refer to this era as the professionalization of youth sports with all the ultra organization that happens. I'm amazed at how young some of the travel teams are starting for different sports in New York, New Jersey, and Connecticut. And I think this shift has come at a bit of a price to our kids. As the orthopedist, top of that list is injuries, and a few more injuries. So we are certainly doing elbow surgery on young throwers, you know, as young as 9, 10, 11 years old that get little leaguers elbow and sometimes shoulder where that fracture is displaced enough that we need to fix it. And there is an absolute epidemic right now going on of pediatric ACL tears. And we got a lot of kids out there playing with pain. So pearl number one that I want everyone to walk away with today is, and this is tangible, this can be for pediatricians, coaches, and parents that are in the audience. There is now literature to support this statement, which is if you have a kid and he is seeing you or she before they are in high school and they are playing more hours of that sport a week than their stated age, that's too many. And that has been shown to be a real risk factor for injury. Such as in this young thrower here that had little leaguer's shoulder, which is a widening here of the growth plate from doing too much throwing. There it is. So early sport specialization, I just need to define it really quick because I am certainly not a fan. It's really when you participate in one sport that's organized for greater than 8, some people say 9 months a year. The other part of it is really during that time, you're excluding and not doing anything else. And we're talking about kids here that are age 12 or less. So why are people specializing early? There is this perception that this gives the athlete a competitive advantage. And let me be clear, there are a couple sports that are early entry, such as like gymnastics or figure skating, where if you don't start when you're 5 or 6, you don't just like pick up gymnastics at 15 or 16. I'm talking about mainly team sports here. But like, I don't think there's anything wrong with the drive to get better. That's why we're all here at 6 p.m. after a work day. We want to learn a little bit. That's why you send your kids to Kaplan or Princeton Review, right? You got to get their scores better. So they go to But it's like that there's nothing wrong with the intrinsic drive, but sometimes when those forces are not intrinsic and they're coming from coaches and parents that like, hey, you have to be doing this, this is the way. I don't think that that's necessarily true. And what is most of the ESS or the early sports specialization heading for? It's that holy grail of a college scholarship. It's like held up early. And Malcolm Gladwell is a fantastic author. I've always really liked Outliers, but there's a couple things that get extrapolated from this book and used to sort of justify the idea that early sports specialization is great. They basically looked at elite musicians, and 10,000 hours seemed to be the cutoff in this famous study on sort of how much it takes to be a genius or really elite. And from this paper, people have extrapolated this from music into sports, and it's not necessarily the same. The evidence is really kind of growing and is clear that really for most team sports, it's actually better if you specialize late being in, high school and not junior high. Couple things, injuries are a big problem when you specialize early. Burnout is another big one. There's some sports where, up to 40-50% of kids are quitting before they're 12 years old. And then the other thing is just from a total body and person perspective, if one person has all their eggs in the basket, like they identify only as a women's soccer player, and they get an ACL tear and can't play anymore, a lot of times their identity is so wrapped up in their sport that there can be a lot of depression issues to deal with. And we even did a paper where it's almost like for some kids, some PTSD type symptoms from not being able to play their sport. So I think there are real dangers of early sports specialization, which is why I want to talk about this. I think it's important. I think if you do late specialization, there's a lower chance of injury. You're more likely to play the sport for longer. And I think we really create a false barrier sometimes to some other kids that might succeed if given opportunities up through later age. So there is a myth out there, and this is pearl number 2, that I do not think you need to specialize in a sport before 12 years old to get elite achievement. And we have a paper that backs this that we did where we looked at Division I athletes in a lot of different sports, and a couple take homes, like the individual sports did tend to specialize a little bit earlier, but there is a real misconception that you gotta specialize before 12 if you're gonna get a college scholarship. And things that were really important that we looked at in the study is that skill acquisition and that intrinsic drive to be better were really the strongest factors for, deciding to specialize. And I think that's healthy. Numerous organizations, AOSSM, our Academy, AAP, and the American Medicine Society for Sports Medicine are all in pretty solid agreement that late specialization for most sports is the way to go. And with our audience today, I want to make it very clear that the role of parents and coaches is immense. Like, you guys absolutely make a difference. We put out another paper in OJSM a couple of years ago that really highlighted for me the importance of parents and coaches. In this study, we looked at like 212 parents in the New York, New Jersey area, and more than 50% of people really wanted their kid to specialize in one sport. And parents also sort of in this study sort of expected their kids to play in college. So they're setting a pretty high bar. And, there's a lot of pressures to growing up as a kid in New York and New Jersey. And this is another one. We put out a paper about 4 years ago now in sport health, because I was really interested in looking at some of the factors that were driving this early specialization. And again, here with a webinar where we're looking at coaches and parents and pediatricians, like, over a third of athletes that we surveyed here, and that was 235, had pressure from a coach to specialize in one sport. 70% of the kids that we looked at wanted to specialize or and play professionally or in college. And like the red line, amazing fact of this was the average age in this study of kids that we looked at for specializing in one sport was 8 years old, which is 3rd grade. That's kind of wild. And just for a different line of thinking, like in Norway, which has won more gold medals now in the last 2 Olympics than any other country of 6 million people, they are completely the opposite of us with youth sports. There is not much organization. There are not these travel teams. They don't start until junior high or high school. So this may be a better model for us to think about and follow if we're trying to minimize sports injuries in our kids. So what are we trying to minimize? I want you to focus on the girl in white here. She's going to get the ball. This is unfortunately an all too familiar sight these days on the soccer field. She's going to dribble down, cut in, plant, and play the knee goals. So currently right now, this is a epidemic problem. There is one girl basically on every high school varsity soccer team is the average that will tear their ACL during the season. And the sad part too is there are some studies now when we look at really good surgeons doing ACL reconstructions in this challenging group, the failure rate can be as high as 20 or 25%. So we want to avoid going to the OR. And people ask me sometimes, well, why is this happening? And it's multifactorial, but I want to show you guys something because I think it drives home the point. Look at how the person on the left jumps and lands, and now look at what our young soccer girl does on the right. There are landing mechanic differences that we're able to see and screen for. And that's why after you have an ACL reconstruction, you need to do physical therapy. And then after that, there's this bridge period where when you're done rehabbing, but not quite ready to get back to sport, there are a place that we have partnered with at Columbia called Exos that I think is really good at rounding out the athlete and getting them ready for sport. And this is also on the prevention side, a plug for the FIFA 11 program for any soccer parents out there. It's a 15 or 20-minute warm-up that has been shown to significantly reduce ACL and other lower extremity injuries if implemented. And final thing I'll leave you with before I sign off is people always ask me, hey, if there's one physical exam thing to do, or if there's one exercise I can do at home, what is it for injury prevention? If you can do a set of 10 on your single leg squat, like this girl, I think your injury risk is going to go way down. Look at how she's staying balanced, centered over the toe and coming back up and not collapsing down over the foot. Like that's a really good looking form there on the single leg squat. And I really like that. And I try to get as many kids into yoga as will go. So final thing, I guess we'll go over the final takeaways, but like, pretty please try to remember that early sports specialization is really not the way. It's not the way to have a happy kid, and it's certainly not the way to achieve elite status. You guys matter as parents and coaches. Your kids, believe it or not, do listen to you. Remember, no more than how many hours a week as their age, and ACL prevention programs work. So I'll sign off and happy to answer any questions at the end, but I hope that was helpful.
That was really, really excellent, Dr. Popkin, and really so many messages and so many takeaways, and we can review those after. And if anyone has questions, to please put them in the Q&A. And now we're going to turn to Dr. Mandel, our pediatric neurologist, who will speak to us about his very common sense approach to concussions. He's going to talk to us, and we'd like to know from him what to do on the sidelines for those coaches out there who are really the front line after an injury, what to look for, what are the high-risk sports for concussion. I'd love for you to expand upon when to send an athlete to the emergency room, Dr. Mandel, follow-up care in the day or two after a concussion has been diagnosed, and then when do we turn to a pediatric neurologist? What is post-concussion syndrome, and when is it too long to have had concussion symptoms? So with that, I turn it over to Dr. Mandel.
Okay, thank you very much, Dr. Radner. So yeah, I'm going to focus this talk for multiple audiences, ranging from the athletic coach to parents to pediatricians. And I just want to start by saying that, concussions are something that are very common. I'm sure that many people in the audience have had a concussion at one point or another because of some sports incidents or something like that. And it's something that we see very commonly in neurology practice as well. And the important thing is to try to understand, most most people with concussions actually do well, but it's important to understand which ones you have to really be careful about and which ones need more care. So I'm going to start by talking about the sideline, which is a place I don't go as a neurologist. I'm usually back in the office, but some of you are probably on the sideline, and when someone has an incident, the question is, what do you do, and what are you assessing for? So one thing that's really important about concussions, and it's a little different. It's a little different from say straining your muscle. If you strain a muscle, or you think you might have strained a muscle, maybe I'm not endorsing this necessarily, but I think advice might be see if you can walk it off, and maybe we can get you back in there if you're feeling okay. It's just the opposite with concussions. Concussions, the approach should be you're not going back on the field unless you prove to me that you did not have a concussion. And if you did have a concussion, you're not going on the field, and that's just the rule. And so what are we looking for? We're looking for symptoms. So there are some constitutional symptoms like headache, like nausea, vomiting, and then there are more specific symptoms for say so-called neurological symptoms like problems with balance, problem with thinking, cloudy thinking, language issues, articulation issues, sort of a fogginess of thinking, photophobia, being bothered by light and by sound, neck pain, and I'll talk more about that. That's really important. Sensory symptoms also really important, and then changes in mood. So any of these things that if someone has an incident of potential head trauma, you really should be assessing that and seeing how they're doing right on the sideline. Certain risk factors that go along with concussion are if there's a high-risk sport. So we already heard from Dr. Lewis about football, but what she doesn't like. In addition to that, any sport where there's a real likelihood of head impact. So hockey, lacrosse, these kind of sports, boxing, of course, things like that. Heading the ball in soccer, getting kneed in the head in any kind of sport. These are all things that can happen. And so, be mindful of concussion in that setting. Be mindful of concussion at young age as well. Younger kids, anybody can get a concussion, but younger kids are sort of more likely to have the rotational force on their head because of decreased neck stability as compared to older kids. So that's more of a concern. If there's a history, as Dr. Lewis already mentioned, if there's a history of concussion or head trauma, that's a real concern in terms of having another incident. Someone has a double hit, multiple parts of the body got hit, maybe in a football tackle or something like that. And then for some reason, females seem to be a little bit more susceptible to concussion as well. And it's unclear whether that's physiological or whether there's just increased reporting of that, but whatever, it's something else. It's also something to consider. Bear in mind that you do not have to have direct head trauma to have a concussion. You can have a body blow or some other incident in which you have rotational force to your head, and that can give you a concussion. So just remember that. And then the other thing, as I mentioned earlier, neck injury. If there's neck injury, any thought about neck injury, you have to really worry about about a spinal cord injury. And if that's the case, you have to stabilize the neck. So on the sideline, make sure you're assessing for that. Now, what kind of things might go along with neck injury? Neck pain, or if there are sensory deficits or motor deficits, then you really have to think about a cervical spine injury. And this is a transition into, when do you send kids, anybody, to the emergency department after an injury? And that's a major one. Stabilize the neck, and if they have any neck symptoms, definitely send to the emergency department. Other things to think about in terms of sending to the emergency department, or not think about, to send to the emergency department if you see this: skull fracture, skull deformity. If there's fluid coming out of the nose that's clear, that could be cerebrospinal fluid. And so that's a reason that could be a skull fracture as well. Bleeding in the ears also could be a skull fracture. Think about the mechanism of injury. If there's a high impact mechanism, some, I don't know, wide receiver getting tackled in a football game, you have to think about an intracranial bleed. So if there's a high impact injury, definitely think about going to the emergency department. If there's loss of consciousness for a prolonged amount of time, greater than a minute, then you definitely should send to the emergency department, because it could be something else going on. If there's a seizure, I think that's obvious, but that gets sent to the emergency department as well. And then if someone's not getting better, if they're getting worse, if they're somnolent, if they're having nausea, vomiting, if they have focal deficits, mental status change, all these things are reasons to send to the emergency department. And I won't go through what we do in the emergency department so much, but it's important for the emergency department physician to assess the spine, really important. Make sure there aren't other traumatic injuries, because those can be missed, and do a thorough neurological exam. Maybe imaging, might be indicated depending on what the neurological exam shows and what the injury was. And then, think about other things that can happen too. So we have to think about, hypoglycemia, dehydration, heat stroke. These are all reasons why someone might be having cognitive issues. And we'll hear later from Dr. Weller about cardiac etiology as well. All right, so that's kind of the immediate concussion treatments and thinking that you should have. And like I said, I'm not actually part of that. I'm more a part of the ongoing care. And some of you might remember, not too long ago, there was this thought that after a concussion, someone should rest for a long period of time, and really rest, like turn off all lights and sit in the dark for days on end. And I had some patients who actually were recommended to do that. And then they came to see me later because they were catatonic. So that's not the current thinking right now, to do that kind of rest. Yes, you should rest. You should have 24 to 48 hours of rest, but it should not be in the dark and don't do anything, because that's too much and it makes kids depressed. And like I said, I actually had a patient who needed months of psychotherapy to get him out of that state. So anyway, taking it easy is basically what I tell parents of patients of children who have a concussion. And then when can you return is the question to athletics and to school. Now athletics, there should be a staged build up. So when the child is symptom free, they can start doing some light aerobics, and then increase that slowly to more intense training, and then maybe exercising that are actually specific to the sport, and then sort of non-contact sport activity, finally returning to practice, and then actually returning to the game, or to actual competition. But that should take each one of those stages that I just mentioned, and I just mentioned 6 of them, should take a day. So that's a minimum of 6 days. And you should not move on to the next level. So don't go on to more intense training if light aerobics gives you symptoms, gives you headache. You should take it easy, go back to the light aerobics and see how that goes before moving on to the next level. And also really important, and this addresses sort of what Dr. Popkin was talking about with people wanting to get back into athletics so they can go into get their athletic scholarship. You can't go back to athletics if you can't go back to school. So no athletics without school, that's very important, and no athletics without any with symptoms or an abnormal exam. So, and these are actually guidelines. New York City has those guidelines for their schools at the very least, that you can't really go back to athletics without those symptoms disappearing. In terms of school, there should be, again, similar to athletics, but a slow buildup to school participation, depending on how severe the concussion was. And I usually say sort of activities as tolerated, but just be mindful that some kids have difficulty with things like tests. And I think that standardized tests in particular should be avoided in the immediate period following a concussion. One little trick that sometimes I recommend is to have kids start late school. Usually the more intense academic activities are in the morning. And so if they show up at school a few hours late for a few days, that might help them sort of acclimate more to the school experience. Important to avoid activities that exacerbate symptoms. So sort of classic for that are video games and screen time. And I don't recommend that following a concussion. Getting good sleep, really, really important. And I think Dr. Lewis talked about 8 hours. Yeah, and sleep can be impacted by concussion. So, you know, it's important to really make sure that kids are getting good sleep so they can function at their best. And then let's see. And lastly, I was asked to talk about sort of ongoing symptoms when you send to the neurologist. And there's some controversy about ongoing symptoms. I mean, there is this post-concussive syndrome, which lasts usually up to 2 weeks. After that, there's controversy on whether it's really post-concussive syndrome or there are other factors in play. Sometimes there's psychological factors, you know, that might be affecting someone's ability to participate in school or whatever. Sometimes there's malingering and other kinds of activities or thought processes, I should say, that get in the way. But if there are persistent symptoms, then that would be a reason to go to a neurologist. So, you know, if there's difficulty with headache after a few days, difficulty with sleep, dizziness, nausea, these kind of things, if these are persistent, then you should consider going to a neurologist. And there are medical, you know, medications that can help with all these things. I was going to say there are also some therapies that can help too. So sometimes when people have difficulty with dizziness, there's actually vestibular therapy that can help with that. So anyway, you know, a neurologist at that point might decide to do more imaging or something like that. And I won't go into that, but that would be the reason to go into it. Anyway, I think my time is up, so I'll stop. And
well, that was really a great overview of a complicated topic. So we really appreciate that, Dr. Mandel. And now we're going to turn to Dr. Rachel Weller, who is our pediatric cardiologist this evening. And Dr. Weller is going to address what are, sort of circling back to Dr. Lewis and the screening for athletics, what are those red flag cardiac symptoms? What are reassuring symptoms? Which symptoms are of concern at rest and which symptoms are of concern during exercise? So with that, I turn it over to Dr. Weller to explore this topic and the symptoms.
Thank you, Dr. Ratner. So I think before talking about the symptoms, it's probably important to talk about who we're screening. And Dr. Lewis spoke about that a little bit, but the truth is a lot of the papers that have been written are talking about competitive athletes when we talk about symptoms and high risk. But the truth is that only about 30% of students in high school are doing competitive athletics and even less in college. So it's really, there's a big group of kids that are just doing recreational sports, and they are as likely to suffer sudden cardiac death. So I think it's a general screening is very important for everybody. And I think a good way to start for pediatricians is the American Heart Association, American College of Cardiology put out a 14-point sort of checklist. And I'll talk about that a little bit, but I think that that's a really nice way to hit. I think they hit a lot of the most important points that are things that you should be looking for when you're going to be thinking about who you can clear and who you should send to a cardiologist because you're not quite ready to send them. So just to talk briefly about the checklist. The symptoms part of it all mainly go through afterwards in terms of symptoms that you're looking for cardiology type symptoms. But I think the important thing, and Dr. Lewis spoke about it, is really family history is really critical. So early family history of sudden cardiac death is certainly an important one. I think on the flip side, I often see patients who are referred because there's, a family history of arrhythmia in their older, when you're 70 years old, or there's heart attacks when you're 70. And I think that's a lot less relevant, but I do think that anything that's occurring, certainly under 50, as I get older, then it changes for what's old, but I say certainly under 50 is important, and I think history is critical, and the same for the student. So I think others are getting a sense for is there family history of not only sudden death, but are there people have, for example, connective tissue issues, so long, thin, Marfan's type patients, because their aorta could be big, and this is not really for me, this is really for Dr. Popkin, but in terms of contact sports, that can be very dangerous. So you just want a good family history. And then in terms of exam, it's hard. I think that there are lots of kids who have a little innocent heart murmur, and I don't think all of them need to be sent if you sort of feel comfortable. But I think that when you start to hear anything that you think is significant, they should see a cardiologist first, because there is acquired heart disease. So kids can get rheumatic fever or other, and certainly post-COVID, we've seen some heart issues, and I'll talk about that. But so if you have a significant murmur, certainly makes sense. You want to make sure that they have good distal pulses. Sometimes it's as easy as just making sure that you feel every kid's distal pulses, just to make sure that there's no decreased pulses, and that in combination with having high blood pressure could be coarctation of the aorta, and that's something that could be dangerous, particularly if you're doing certainly sports that are increasing your blood pressure a lot. So you'd want to rule that out. And these are all very fast things that you can do with every single office visit that I think are really, really important. Okay, so when you think about who are the kids who are dying suddenly, there's the classic study that was in 2009 with Dr. Marin and his group, and they kind of looked at a very large number of, and this was again competitive athletes, and what they found is by far number one was hypertrophic cardiomyopathy or thickening of the heart muscle. And this is sort of what you'll hear when you hear about kids who are who drop dead on the field. That's certainly the number one thing that you have to think about. And then number two is actually something that's much more subtle and that we don't think about, but is that there's a coronary artery problem. So I think the important things in the way to sort of explain to parents is with adults, you think about the coronaries, right? They give oxygen and blood flow to the heart muscle. So in an adult, you worry about the coronaries because they can get clogged, and that leads to a heart attack. But in kids, that's extremely, extremely rare. But what we can see is that the coronary artery comes from a different place in the heart. So your coronaries come off the main blood vessel, the aorta, and the right should come off the right side and the left should come off the left side. But what we can see is that, for example, the left coronary comes off the right side and it has a long distance to travel and it can be compressed. So these are things we don't actually hear about a lot, but actually when they looked at the data, that was actually the second most common reason for kids to die. And then lower was inflammation of the heart, and actually lower than that even was sort of abnormal heart rhythms. That's actually a much less likely reason, but it is a reason that they can die. Studies later have also shown that more than this study is that there's sudden unexplained death. And I think that's the hardest, and that's also hardest for families, but that you do an autopsy, there's just no clear reason. And there are many other things like we were talking about before, heat stroke and other issues that may cause sudden death. So it's not all the heart. So sort of with that as a background, to just kind of go through then what are the red flags. And I think all of us here, you can tell that our push is to participate. I think it's too easy as physicians to, and understandably, you never want something bad to happen to a child. On the other hand, I think we forget how important it is to participate and to be on the, whether it's the playing field or in PE class or on the dance floor, it doesn't matter, but it's really important. And so you don't want to restrict unnecessarily. And I think that's the important thing. But I think that when you think about what are really the important things mid-exercise, and it sounds silly maybe, and even it's not really, because there's so many times that we'll see patients who may have symptoms with exercise, but they also have it at rest, and we'll sort of talk about that. But I think if it's a really clear mid-exertional symptom, take that very seriously. So one, of course, is chest pain. And it is hard because lots of kids, number one, you can have asthma, you could have indigestion. But if you're really clearly having mid-exertional chest pain, particularly to the point where, and I always ask, do you feel like you need to stop when you feel the chest pain? And I think that's an important way to look at it. So if the kids are very uncomfortable, that is a symptom to take seriously, and that could be cardiomyopathy, and that certainly could be a coronary artery problem. Same with fainting. Lots of kids faint, lots of teenagers faint. And that's okay, and we can talk about what's sort of reassuring. But if you are mid-exercise and you faint, that can also be that's something I would take very, very seriously. Because usually when we talk about fainting, that's okay. That's because your blood pressure has gone down a little bit, you're a little bit dehydrated, or it's very hot, or whatever other reason. But when you're actually in the middle of doing sports, your sympathetic system is going, your heart rate is up, and you shouldn't have that kind of fainting. So mid-exertional fainting is certainly something to really think about. Again, lots of reasons, the heart muscle, coronary, that's where you get more of your sort of genetic problems. So something like a long QT, where you have an electrical system that is taking longer to relax, and you could have an abnormal heart rhythm from that. So those are the things you think about with fainting. Same with mid-exertional palpitations, dizziness, real exercise intolerance. So a kid you knew well, or your own child, you know that they've been doing soccer and playing fine, and now in the past few games, they just don't have the same exercise tolerance. And those are things, again, that you would take seriously. At rest, most things are more benign, but if you have episodes where your heart rate suddenly starts to go fast and then stops abruptly, that is more often something you would think about as being an abnormal heart rhythm versus just very normally kids getting a little bit of heart racing, whether it's anxiety, whether your sugar drop. But when you have these very almost clear onset and offset of your symptoms, then that tends much more likely to be an abnormal heart rhythm, particularly if it's persisting a few seconds. That's usually not going to be, but if it's lasting 10 minutes, that sort of thing, then you want to think about that. It's more likely to be an abnormal heart rhythm. And then finally, and this sort of gets a little bit to, I hate to use the word COVID because no one's used it tonight, but I'm going to use it. So when we think about the worries that were around COVID and the heart, is really the same thing that we can see with other viral illnesses, which is that you can get inflammation of the heart post-viral or post-COVID. So symptoms of that really tend to be, they're a little less clear, and that does make it a little bit harder. But it's chest pain that's really there a lot of the time, often positional. So you may feel better sitting versus laying flat, or even vice versa. with sort of heart racing and new shortness of breath. So these are all signs that you might have inflammation of the heart. And if you've had either COVID or you've had any other sort of febrile or fever type illness, and then you develop the symptoms, they most often, especially with COVID, tend to be within the first week, which is why part of our recommendations that when we put out our recommendations for when to return to sports after COVID, even with mild COVID, is to really wait a week, because you kind of want to see if these symptoms are going to blossom. Having said that, it is pretty rare. So I just re-looked at the numbers. We've been looking at these numbers as we sort of put out recommendations, but I just re-looked at the numbers, and the highest risk group is boys, sort of age 12 to 17, and then the young male adults. But the risk of having inflammation after COVID in that group right now is about 0.06%, so extremely low. And the reassuring thing is the cases have been mild overall. Most cases seem to be very mild. And then there are rare cases after vaccines as well. Again, the numbers are about 0.02%, even in the highest risk group. So it's, there's symptoms that are important to be aware of, but actually know that with any viral illness, you could have it. And so I'd be aware anytime that you're having sudden onset of chest pain, shortness of breath, palpitations following some sort of fever, cough type of illness.
So
Yes.
Dr. Weller, we're just going to put up, since we're nearing the end, Dr. Weller has two excellent slides that just give these pearls of what are worrisome symptoms, what are red flag symptoms, and what are reassuring symptoms. And then she has one last pearl, which will lead us to our conclusion tonight at the end of the hour, which I think is really excellent. So if you could switch to her second slide, that would be great.
I just want to, one thing before you switch. I think the very important thing to remember, if you look at what's not worrisome, is symptoms following exercise. It's very, very common once you've been running and then you stop to then get lightheaded and to even faint. And I think that's where the history really, really comes in. I think it's when you're seeing kids, or if you're a parent and you notice it, it's very common. Once you stop exercise, then your blood pressure can drop. So, and then you may faint from that. So it's much less worrisome.
So, and just if you could switch to Dr. Weller's second slide, which I think is a really excellent takeaway as well.
And I think this is the most important slide in a way for me, which is that, you know, we went through everything. It is very hard to rule out all of these things. EKGs are very often not going to be reliable. And even echocardiograms, which I do day in, day out, finding coronary abnormalities, you need to be pretty highly skilled, and they're actually easy to miss, and sometimes we even debate it. So to make you feel better in a way is what's the best that you can do, and this is for coaches, this is for parents, is AEDs. They've become much more easily available, and truthfully, every school should have defibrillators available. And also, if you have at least some of your staff trained in CPR, it's absolutely life-saving. We just had a patient just came in, fainted in the middle of running, and they'd had another student in the past that happened, and some of the staff started CPR. They did an AED, and the girl's doing beautifully. And so in the end, that's probably the most important take-home message.
So with that, just to circle back, because we are at the end of the hour, I really think this has been a especially rich discussion from Dr. Lewis and all that she told us about the pre-participation physical, and especially about the history and about preparing for that history, to Dr. Popkin and all of those really great insights regarding sports specialization, and that yet again, we need to look to Scandinavia for some answers. to the common sense approach from Dr. Mandel, the common sense approach to concussions, and to Dr. Weller's going through in great detail into all of the concerning cardiac symptoms and those that are a little bit more reassuring. And then to that last tip about AED, CPR, and how those can be life-saving. And I'd really like to thank you all for joining this webinar. We had a very large audience. Please look out for our summary email, which should come within a couple of weeks. I think we answered most of your questions in the Q&A while we were broadcasting this webinar. And stay tuned for an email about our next webinar, which will be on November 1st. And that will be a discussion amongst our pediatric infectious disease specialists at Columbia Children's Health about emerging infectious diseases in children. And I hope there are not that many more of them to discuss at that point, but we will have a very robust discussion that evening between those specialists. And for those pediatricians out there, keep an eye out for our CME announcement. We have our specialty updates for the general pediatrician, which will be held virtually December 3rd to 4th. And that has a really great roster of speakers. So thank you all again for joining us tonight. I hope you all learned something. I certainly did. And good evening.